have our next speaker, Dr. NEERAJ SANDUJA, who's the founder director of Vian Eye and Retina Center, Gurgaon. And he has a different interesting case to show. On to you, Dr. NEERAJ.
Thank you, Chitra ma'am, and good evening, everybody. I'll be showing a little bit different when any complication of cataract surgery has already happened, like dropped intraocular lens. And this was a case of spontaneous subluxation of the intraocular lens into the vitreous cavity, and the patient was sent to us. So we had planned for glued IOL in this patient. You can see we are making scleral flaps 180-degree apart in the horizontal meridian. And the thickness of the flaps have to be done in such a way, like it should be 2/3 anterior and around 1/3 posterior thickness. And it has to be done with a crescent blade. And you can see that scleral flaps have been made. Now on the opposite side, we are making a scleral flaps. Now the scleral grooves are being made, which are going along the circumference of the limbus. And you can see with the this 26 gauge needle, we are making scleral flaps, and haptics have to follow that. And after these scleral flaps have been made and grooves made, we are putting a trocar cannula and now making a 20 gauge entry. Now the globe is formed, and we are making a 20 gauge entry into the 1.5 millimeter from the limbus into the vitreous cavity, to which the haptics of the intraocular lens will be put. Now you can see the whole capsular bag and intraocular lens is lying over the vitreous, over the retina. And now this thing is being held by with end gripping forceps and brought into the anterior chamber. And we are holding with the end gripping forceps, which are 23 gauge forceps. And gently we are prolapsing this intraocular lens into the vitreous cavity, taking care the cornea should not be touching the lens. And once this lens has been prolapsed into the anterior chamber, now it will be expanded through the corneoscleral section. We are putting viscoelastic into the anterior chamber and enlarging the corneoscleral section. Everything has to be done in a very systematic manner. And you can see we are pulling this intraocular lens gently with 2 instruments, and this will be brought out of the anterior chamber gently. And you can see, and infusion cannula has to be on because the intraocular pressure has to be maintained throughout. Now this IOL bag is there, and now we are going with a end gripping forceps into the vitreous cavity through the scleral entry which we made, and going with A-type injector and injecting 3-piece lens. And the leading haptic has to be caught at the edge of the haptic itself. And you can see that the lens, one way the lens is being injected, and the other way the haptic is being brought out very gently, so that you should not damage the haptic also, and it should not break also. And it has to be held at the tip of the haptic only. And now you are making space for the optic to go inside. Now your assistant holds the tip of the haptic, and you have to go through with the end gripping forceps from the other side. And you now gently hold the other trailing haptic with the McPherson forceps and take it into the vitreous cavity, and then just gently bring it out along the circumference of the globe itself, because you have to be very cautious. You should not break the haptic at this juncture. And once the haptics are out, you can leave it comfortably. It will not go inside. It will not just retract inside the vitreous cavity. Now you are tucking the haptics into the scleral grooves which you have made, and it has to go along the circumference of the globe. And this also has to go along the circumference. If it is not along the circumference, you may land up with some astigmatism because the IOL may tilt also. So this is very important. And once the IOL is in place, we are putting one single suture because the section was enlarged because of the IOL explantation, and we are taking out the infusion cannula. And you can see throughout we had maintaining this intraocular pressure also. Now putting the glue over the scleral flaps, and just doing it over the other side also, putting scleral flaps back in place. Now keeping the conjunctiva over there. And this is how we can do all drop intraocular lenses or any drop lens where posterior capsule or anti-capsule support is not there. We do it with the glued IOL. Thank you very much.
Yeah, excellent demonstration, Dr. NEERAJ. So the tips are that the 2 scleral flaps should be exactly 180-degree apart, 2 millimeter from the limbus, and we should ensure equal amount of haptics are being tucked in. and so that there's no tilt. And I suppose the other important thing you said is you should hold the tip of the haptic so that it doesn't break. But I'm going to ask you one question here. Do you think when you're doing a glued IOL, this was anyway a combined retinal procedure also, but if you're just doing a glued IOL, you've not had an IOL drop, but you have lost the capsular bag, would you believe that just doing an untreated vitrectomy is enough? Or do you think they do better if a past planar vitrectomy is done, the outcomes are better? Is one question I have.
Yeah, actually, I'll tell you with my personal experience also. Once some retina surgeon is doing this procedure, good IOL, or some anterior surgeon is doing, mostly they pump up a lot of viscous into the anterior chamber, which goes into the vitreous cavity and causes a lot of inflammation, glaucoma in the postoperative period. By this trocar cannula, putting a maintainer, so the need for a lot of viscous fluid is avoided. And second thing, once you are making the scleral entry into the sclera, 1.5 millimeter from limbus, sometimes you land up into bleeding also. And I've seen people having a lot of vitreous hemorrhage once this glued IOL is done. So if being a retina surgeon, if we are doing so, we are able to control all these complications on the table itself. But yes, it can be done.
So you believe that instead of using an AC maintainer, doing a using a trocar cannula and a past planar vitrectomy would be ideal, and the whole thing managed by a retina surgeon would be the best way to go.
Yeah, because any surgeon has to be standby.
Yes, I agree. So the other one simple question which I am going to ask is, does it mean that keeping in mind, of course, those late in the bag dislocations are very rare. It's not happening often enough. But does it tell us in this podium here that we think of using a CTR for a high myope or a retinitis pigmentosa case, or in a case of a PXF? Do you feel there is an indication at all, or all of us believe that these things have to be taken on a case-by-case basis?
I think this thing should be taken on a case-to-case basis, because patients who have undergone vitrectomy in previous time, they are more likely to develop such type of spontaneous dislocation of the intraocular lenses. But generally, rarely seen studio solution people developing such kind of spontaneous dislocation.
A CTR won't prevent the zonules from giving way. So yes, you'll have the whole IOL bag CTR complex going down, yes, rather than it being protective. So if you have something sutured like a CTS.
Yes.
And then actually taking out this endocapsular ring is, I think, a more uphill task than taking out IOL, because it is such a thing.
Yes,
you have to take it out without damaging the retina. I've done that. Even one of mine, he did the scleral fixation IOL, patient developed glaucoma because of the vitreous hemorrhage. Surprisingly, when I had gone inside, I saw a large endocapsular ring also into. So I had to take out the vitreous hemorrhage, control glaucoma, and take out the endocapsular ring through the gap between the scleral fixation IOL and the iris without damaging the
So a good idea to remove the endocapsular ring is to actually cut it into 3 or 4 pieces, because that makes it easy to get it out.
I understand, but if you go with considering the anatomy of the globe, you are taking in a very circumferential manner. I've got that video also, but so it is also because cutting this thing PM in different pieces may cause a lot of injury. When you are trying to pick it over the retinal surface, you can damage the retina.
Yes.
These edges are sharp once you cut it.
Yes, yes. Thank you very much for the very important points brought out. Thank you, Dr. NEERAJ.